Alright, before we begin I will wash my hands and put on a pair of gloves. So, good morning, my name's Julia Tihuia, I'm from AUT and I'll be doing a neurological assessment today. What's your name?
Stephen Charles Tihuia.
Okay, and whereabouts do you live?
8 Waiha Street, Turu.
Oh, that's good. Okay, so today I'd like to do a neurological assessment. That might mean that I have to get you to perform some tasks and I may need to touch you. Is that okay with you?
Yes, that's fine with me.
Great. Okay, before we start, are you in any pain?
No, not at all.
So no pain, that's good. Do you have any headache?
No.
Okay, so if the patient was in pain, then I'd have to go through the pain scale thing. I would use OPQRST, finding out all about the patient's pain, and I'd find out how bad their pain was on a pain scale of 0 to 10, 0 being not much at all, 10 being really bad. Okay, so if the patient had a headache, that can be like the worst headache of your life. That can be indicative of a brain bleed, and that patient becomes status 1. Also need to consider if he had any cervical spine pain, if he'd fallen, that we'd need to consider immobilising the patient. Okay, always before we carry on with anything else, we need to check our ABCs, airway, breathing and circulation. Okay, alright. So just starting off with a general impression of the room. Okay, so I notice that the room is tidy, there's no mobility aids around, no medication sitting by the bed, doesn't appear to have any signs of drug or alcohol abuse. The patient is conscious, comfy, at rest. It's not short of breath, it's not sitting in the tripod position, not using accessory muscle use, it's not got regular or irregular breathing. So if breathing was abnormal, that could indicate a head injury, in particular if respirations could get up over 40. That's because from uncontrolled stimulation or inspiration of the respiration centres. I notice that the patient is a good colour, he's not flushed, he's not pale, not diaphoretic. I'm looking at his head, I can't see any fluid coming out of his nose or his ears or anything like that, or any signs of any bruising. I notice that the patient is holding his head straight, he's not leaning to one side, there's no droops, and he's not combative. Okay, so leaning to one side could indicate a stroke. Okay, so we're going to start the assessment now. So to start off with, can I please get you to stand, Stephen? Okay, can I please get you to walk in a straight line just down to here and then walk back again? Okay, now walk back, thank you. Okay, now can I get you to repeat the same thing, this time going heel to toe like this? Okay, and turn around and go back. That's great. Now can I get you to hop on one foot? Now on the other foot? That's great, thank you. Now can I get you to put your heels together like this and close your eyes? Oh, that's good. Patient has really good coordination, really good balance, absolutely no issues there, really nice and steady. Okay, if the patient had a broad stance, then that could be indicative of a cerebellar disease. Okay, Stephen, would you like to sit back down on the bed again, please? Okay, so I just need to have a look at your eyes. Okay, so looking at both your eyes, they're both equal, they're not dilated, they're not fixed or anything like that. Can I get you to follow my finger, please? That's good, there's no wobbling or shaking or anything like that. Okay, both pupils are equal, not dilated, not fixed. Can I get you to smile for me, Stephen, please? Good, the smile's nice and equal, that's really good. Okay, so anything that was unequal there could be indicative of a stroke or a brain bleed or something going on up there. Okay, Stephen, can I please get you to squeeze my hands? That's good, nice equal strength. Okay, Now what I want you to do is hold your arms out like this with your palms up and shut your eyes. That's great, there's no drift, everything's nice and equal, so that's really good. Now I want you to please put your hand on top of my hand, like this. And keep going like that. Okay, we can stop now. That's good, so the patient has really good coordination, so there's no problems there. Okay, so I'm going to hold up two fingers here. I'm going to hold up some fingers. Can you tell me how many fingers that I'm holding up?
3 fingers.
Okay, that's great, thanks. So the vision is really good. If I had a pupil torch, then I would put the pupil torch into his eyes to see whether they constricted to light. Okay, so non-restricting pupils could also be a sign of a brain injury. If they were pinpointed, that could be a sign that he was taking opiates, so we can have head injuries from poisoning and that sort of thing. Dilated pupils could also be a stress response. Okay. Next we are going to just have a look at your legs briefly. Okay, so what I want you to do, can you lift your knee up, bend at the knee there, that's good. Okay, can you get this heel please and run it up and down that leg. That's good, there's no tremors, really good coordination. Can you do that on the other foot now please? Thank you, that's terrific. Okay, can you lift that leg up from the knee? Yeah, and the other one, and back down. That's really great. Okay, so in summary, Stephen has no signs of any neurological deficits. I can't see any sign of any brain injury. The fast test was good, there's no signs of drug or alcohol abuse. He has a good level of consciousness, good coordination, no tremors, no shaking. His stance was good when he was standing and he was able to obey commands really well and follow instructions. Okay, so if I had more time I would perform a full cranial nerve exam. Also important to note, if the patient had a lower level of consciousness, that we would start looking at how alert he was, and we'd also try to look into reasons for this. So we would go into what a mnemonic called AEIOU tips. Okay, so that covers a whole lot of things that could be possible reasons for a lower level of consciousness. Alcohol, epilepsy, insulin, overdose, uremia, trauma, infection, psychosis, stroke. Okay, just to name a few. Okay, so also important, I would make sure that he was not diabetic, because having a low blood glucose, not getting enough glucose to the brain, that could also give a lower level of consciousness as well. Anybody, when we're just asserting what his GCS is, that's the Glasgow Coma Scale, anything under 9 we would make the patient status 1, so he then becomes a high acuity patient. This patient is conscious, alert, orientated, able to obey commands. If he had lost consciousness, we certainly wouldn't leave him at home, and that also makes him a bit higher acuity. He would need to go to hospital to have x-rays to rule out having a brain bleed. We'd make sure that we take all the vital signs, the blood pressure, the heart rate, temperature, blood glucose, 3 leads, 12 leads, O2 saturations, all that sort of thing. And we also need to reassess the vitals against the first lot of baselines to make sure there's no changes. That's really important. So things like low blood pressures and narrow pulse pressures and things like that could be indicative of something wrong. Okay, we need to do a full primary and secondary survey to rule out that there was nothing else wrong, especially if he had fallen. Okay, that's it for today. Thank you. Okay, thanks, Stephen.
Thank you very much.